Okay, so now keeping in mind what we were just talking about, the electrical activity that's going on in the heart, what does that look like on the ECG reading? So if you look at the ECG reading, the first deflection that you're going to see, which remember is an up or down, is this little hill sort of deal right here, and that's called the P wave. And what does that correspond to? That corresponds to the depolarization. Remember, we were just talking about the depolarization means getting closer to zero or less negative of the atrial myocardium, which is the muscle of the atria. And what that's going to cause to happen is that the atrium are then going to contract. And what happens when the atrium contract? Where does the blood go after it leaves the atrium? It goes into the ventricles, right? So the atrium contract, and then the ventricles start to fill, and that's what you're seeing on the P wave right here. The next deflection is larger, and it's pointier, and that is called the QRS complex. And what that correlates to is the depolarization of the ventricle myocardium. So first we saw the atrial myocardium, and now the impulse has been transmitted down to the ventricles. And the ventricles are bigger, right? So they're going to give you a bigger jump for electrical activity when they start to depolarize, which is going to cause them to contract. And what happens when your ventricles contract? They pump blood out to the body, right? Through the pulmonary and the systemic circuits. So that last deflection, that last hump that you see over here is called the T wave, and that represents the repolarization of the ventricle myocardium. So remember we talked about how it's just as important for things to relax as it was for them to contract, and it's just as important for things to repolarize, in other words, go back to that negative, in order for them to be able to go back to the zero or back to the positive state of things, which would allow them to do the next contraction. So the question is, you can see here the T wave is correlating to the ventricular myocardium. What happened to atrial repolarization? Did the atrium not repolarize? Yes, they absolutely do. What goes up must come down, right? But if you see here, the P wave is correlating to the atrium depolarizing, right? So when would they have to repolarize? Here, right? This here, the QRS is the ventricle depolarization, the T wave is the ventricle repolarization. The P wave is the atrial depolarization. So the atrial repolarization is happening right here. The question is, why don't you see it here? And that's because, again, the ventricles are so much bigger than the atria and have so much more mass and electrical activity that their QRS complex is over top of the atrial repolarization, so you just can't see it on the reading. So we talked about the deflections, now we have to look at the intervals. And the PR interval is the first important interval, which goes from the start of the P wave to the start of the QRS complex. And this is representative of the amount of time that it takes to send that electrical impulse or signal from the SA node, which is where it originates, through the entire conduction system. And this is really, really important because if it's longer than 2 seconds, then you must have a problem. Some people get confused and think, well, if you had a block, then it wouldn't be able to travel, so it would actually get shorter. No. If it's completely blocked, you're not going to have a heart rate at all, right? This person is probably dead. If it's partially blocked, that means it's having a harder time getting that signal through here, and that means that this is going to be a lot longer than it should be. So the second important interval is the QT interval, which is basically the rest of this, and that's the amount of time from what? Well, this is representative of the depolarization, right? And this is a repolarization. So that's the amount of time from one to the other, the amount of time that it takes to repolarize after you've contracted. So we took some vital signs in class, and the first one that we took was the pulse. So it's hard to tell rhythm. You can, if it's really an abnormal, a noticeably abnormal rhythm, then you can tell from the checking of somebody's pulse, but usually the thing that you can tell from taking somebody's pulse is just the rate. So we took the radial pulse, and the radial corresponds to the radial artery, right? We take pulses in arteries because why? Arteries are high pressure systems, right? So they have higher blood flow, so it's easier to feel. You'd have to really dig down there to be able to feel the pulse in somebody's vein. And even then it's not going to be very strong because it's a lower pressure system, right? So the radial artery is going to be by the radius bone. And if you remember from Anatomy 1, pinky's up, so the ulna is here. The radius is going to be on this side, on the thumb side. And we took their pulse with 2 fingers because why? Because you have a pulse in your thumb. So if you check somebody's pulse with your thumb, you're probably feeling your own pulse and not theirs. The other places that you can take pulse are carotid, and the carotid artery is in your neck. And there's other ones too that are harder to find and that we're not going to look at in class, like the brachial artery, which is in the arm, or the femoral artery, which is in the leg. Sometimes you can feel a popliteal pulse, which is that one behind the knee as well. But we talked about how it's really important that you do not squish the artery. Some people, especially starting out, can't have a hard time finding the pulse, so they push down really, really hard. And let's say you have an older patient, right? You have a little old lady for a patient, and you're taking her carotid pulse, which is in her neck. Why don't you want to squish that? Well, what happens when you squish it is you cut off blood flow, right? When you squish it like a tourniquet. And what happens when you cut off blood flow in the carotid artery? What does the carotid artery feed? It feeds the head, right, and the brain. So you're going to cut off the oxygen supply, you're going to cut off the blood supply to this little old lady's brain, and most likely she's going to pass out. So we also took blood pressure, and we talked about how blood pressure is really, really important because it's a measure of a lot of other things. And blood pressure corresponds to the amount of force that's going to be exerted by the blood against the walls of the blood vessel during contraction and relaxation. So during contraction, the amount of force that's being exerted by that very forceful push of blood through the arteries is going to correlate to the systolic, which is the bigger number on the top of the blood pressure, and the amount of pressure that's left after the beat during relaxation is going to be the diastolic pressure. If you subtract the systolic number by the diastolic number, so the top number or bigger number by the bottom number or smaller number, the result that you get is something called pulse pressure, and that's important because it represents the difference between the highest possible amount of pressure that you see and the lowest pressure amount that you see. And that can be indicative of a very big problem. If this number is too big, that means that there's not enough relaxation going on during diastole. Sphygmomanometer is one of my favorite words ever. It's really fun to say, but on a more important note, it is the name of the blood pressure cuff that you use to check somebody's blood pressure. So they used to say 120/80, and I think your book still does for normal blood pressure, but now the AHA, the American Heart Association, is really leaning towards 110/70 as being the ideal blood pressure that we want to look for. But anything above those numbers is considered hypertension, and of course it's a huge, huge problem. It's very, very common in our country and other developed countries, and it's correlated with obesity and heart disease and a whole bunch of other not so nice stuff. But there are people who are on the other side of the spectrum as well. So hypotension would be if your blood pressure is lower than the 110/70 number or 120/80. And the big thing that I wanted to point out with hypotension is something called orthostatic hypotension. So ortho is like body position, and orthostatic is body position. So it's a change in body position. So basically what this is, and some people have it naturally and others have it because of some medical condition, or it can be a very, very common side effect of a lot of different types of medication. And the most common place that you're going to see it is people who are actually on blood pressure medication. So they have hypertension, but they're on high doses of medication for it to lower their blood pressure. So what they end up with is orthostatic hypotension. And you can see this very easily because it's what happens when you are sitting or laying down and then you go to stand up really quick. In a normal, healthy person, your body is able to adjust very quickly to that change in center of gravity, to that change in pressure, and accommodate itself accordingly. But in disease states, in different medication usages, you lose that ability to accommodate very quickly. And so what'll happen is that they'll go to stand up and they'll fall back down. So this is really something that you have to watch out for and warn people about when they're taking certain types of medication. Also, when you're taking blood pressure, it's important not to keep the cuff inflated on the same arm for more than a minute. And this is kind of like the don't push down too hard on the pulse thing, except luckily we're only talking about potentially losing feeling in that arm, but it's still not a very pleasant thing for your patient, so just be careful of that. The end.